Welcome to our LinkedIn live chat. I'm Christy Teiglin. I'm a vice president in our research science division at Inovalon, and I've been working closely with health plans and life science organizations for more than a decade, and using the great data that we have at Inovalon to hopefully improve health equity, health outcomes, which is really my passion. I'm really excited today to be joined by Boris Babson, who is on the research faculty and also a researcher at Harvard Medical School. We're both happy to be here today to give you a preview of our fourth research paper. We've done a series of papers and analyses on the two Medicare programs, traditional Medicare fee-for-service, and then the growing Medicare Advantage part of Medicare that is now more than 50% of Medicare. So this is a long-term collaboration between Inovalon and Harvard Medical School. And I hope that we can share some really new, useful insights today, focused today on the importance of plan design in Medicare Advantage. So I'm going to turn this to Boris, and can tell the audience a little bit about yourself, Boris.
Thank you, Christy. And first of all, it's been a real pleasure and a privilege to work with Christy and her team and Inovalon broadly on this research effort. As the saying goes, research is only as good as the data powering it. And there's really no better, more comprehensive data set for studying Medicare Advantage than Inovalon. So we've been able to do some really interesting work that I'm really excited to discuss with Christy. As for my own background, I'm a health economist by training and researcher at Harvard Medical School. I've been focusing primarily on Medicare and Medicare Advantage in my work for the past 10 years or even over 10 years. And in addition to my academic and policy work on the topic, I've worked closely with health plans and with other healthcare organizations that have a stake in Medicare.
Thanks, Boris. Maybe, Boris, we could start by expanding a little bit on the data source, on the unique data source, because I think our audience will be interested in hearing more about why this project is so different, how the data, allowed us to really control for pre-existing differences between plan members, to really isolate the impact of plan design, that's not muddied up by who enrolls in the different types of plans. So tell them about our data.
Yeah, absolutely. So, I'm a data nerd at heart, so I might find all of this even more exciting than the rest of you. But the thing about healthcare data in America is that it's generally very siloed. So different organizations have different parts of the puzzle, but very rarely do the different pieces of the puzzle come together. So when studying Medicare, one consequence of all of this is, there's one set of data that typically covers those people in Medicare Advantage, another set of data that covers those in Medicare fee-for-service, a third set of data that covers those people who are about to age into Medicare but not yet in Medicare, and pretty much no data sets out there that basically connect all three together and where you can track people as they, for example, age into Medicare, cross this age 65 divide, or track the same person as they switch between Medicare Advantage, Medicare fee-for-service, commercial insurance, these different forms of coverage. And where Inovalon's data is really unique is not only in broadly covering a lot of different patients, broadly nationally representative sets of patients who are under these different forms of insurance. Inovalon's data is also unique in basically connecting all these different data sets together. So we can follow people as they cross these different forms of coverage. And that ended up being extremely useful for our studying, being able to compare Medicare Advantage, Medicare fee-for-service, and do look at other important questions in Medicare Advantage, because we can basically account for differences in who enrolls in Medicare Advantage versus Medicare fee-for-service by looking at what's going on with people right before they enroll in Medicare, during the year before they enroll or 2 years before they enroll, when they're still under commercial coverage, when everything's the same, when things are still apples to apples. And so that allows us to statistically adjust for any differences between these different populations in a much more rigorous way than has been possible with standard data sets, conventional data sets. And we're really able to do a much more rigorous causal job in our analysis, and also dive into questions that no one's really been able to answer. And one example is a lot of the choice to whether to enroll in Medicare Advantage versus Medicare fee-for-service. It happens right at 65, when people age into Medicare, but people haven't really been able to study this choice or try to understand what the population even aging into Medicare looks like, just because the data hasn't been connected. But at Inovalon, the data is all connected. There's a lot of data. It covers 30% of all of those, whether in Medicare Advantage, commercial, and 100% of those in Medicare fee-for-service. So it's very nationally representative, broad sample, and just allows us to do a lot of really exciting things.
So that's the really cool thing about what we were able to do, is because we primary source our data and we get data that's identified as a qualified research entity at Inovalon, we really can link data from when people are commercially insured to when they're in Medicare, and look at them for 4 years, 2 years before they joined and 2 years after. So imagine all of the questions that gets rid of, because what you always hear, but it's all who enrolls. People who enroll in Medicare Advantage are healthier. People who enroll in Medicare Advantage are this. And we are able to control for all of that. So it really makes for very, very powerful research that really has not been able to be done before, and really can get at the actual program effects versus differences in people who enroll that already existed, right? We're controlling for all of that. So Boris, let's talk a little bit about this particular analysis, and maybe explain to the listeners why we did this plan design analysis. Why did we think it was important to look at this issue?
Sure thing. So what really motivated our analysis was just this conventional wisdom that all of Medicare Advantage is the same, that it's a monolith. And, just given all the data that Inovalon has on different kinds of Medicare Advantage plans and things we were seeing in the data, it just seemed like that conventional wisdom might be wrong. There might actually be a whole variety of different types of MA plans, different carriers offering these plans, and just really different outcomes under different plans. So just, the data really motivated this, and we ended up doing a deeper dive on this question and really finding that, in fact, there were massive differences even within Medicare Advantage from one plan type to another.
Yeah, and so, some of the outcomes, I think maybe people say, oh, that was a no-brainer. One that stood out was that, we confirmed that zero premium plans attract the more socioeconomically disadvantaged populations than higher premium plans. But really, if you think about what that means, it really underscores how Medicare Advantage plans can appeal to these disadvantaged populations because of the lower premiums, because of the lower out-of-pocket costs. And then, more importantly, we found that, between, the choices in Medicare Advantage, the HMOs, the managed care organizations versus the preferred provider organizations, that the HMOs that really had these managed care policies that have more coordination of care, ended up, after you control for all those patient characteristics, their disadvantages, their low income, their low education, they don't have transportation, all of those things, those disadvantaged members who enroll in HMOs really ended up having lower utilization, lower costs, even within Medicare Advantage, compared to those who enrolled in preferred provider organizations in Medicare Advantage, right? So not only did we see in our earlier work that just in people in Medicare Advantage overall, after you control for all, yes, they're more disadvantaged, they're more socially disadvantaged. But after you control for all of that, they had lower costs, lower healthcare utilization, better quality outcomes. That's also happening within the plan types in Medicare Advantage. And I think that was something that was a little surprising, Boris. What were some of the findings that stood out to you as a little surprising?
So to borrow some words that Susan Dentzer used in our previous webinar, I found it surprising just how much people were creatures of habit. So how much people stuck with the plan type they were on pre-65 when choosing a Medicare Advantage plan.
Mm-hmm.
Post-65, the extent to which people who were previously on commercial HMOs ended up in Medicare Advantage HMOs, how much people in commercial PPOs ended up in Medicare Advantage PPOs, and then, more broadly, the factors driving which people end up enrolling in Medicare Advantage versus Medicare fee-for-service. And some of these findings that we uncovered, I don't think they're just surprising to us. I think they'd be just as surprising to a lot of health plans, because a lot of these questions around, plan design and what kinds of beneficiaries different plans attract, or what different plans end up doing in terms of outcomes, it's really a blind spot for everyone, not just a blind spot for policymakers or analytics firms like Inovalon, but historically it's been a blind spot even for the health plans themselves. And with the data that Inovalon has, we're really able to fill in this blind spot.
Yeah, we can really help plans understand what kinds of plan design features will attract various populations and what their needs are going to be, right? What kinds of benefits they're going to need to take care of those members that they're attracting. So really, really important point. I was also especially interested, as I always am, and how this all relates to health disparities and health equity. The effect of plan design on addressing some of the socioeconomic, disadvantages we found in Medicare Advantage, which we already knew from our earlier work, as I said, already knew it attracts a more socioeconomically disadvantaged population. But again, those in Medicare Advantage HMOs have even greater social disadvantage than those who end up enrolled in Medicare Advantage preferred provider organizations. And that stems from, as you said, the type of insurance they had before when they were covered by a commercial health plan. But again, after we control for all of those patient characteristics, and their pre-existing conditions and their healthcare utilization before they join Medicare, we do see the benefits of joining these HMOs. They're getting benefit from the managed care model that includes more outreach, more care coordination, better integration of services, better maybe discharge planning from the hospital, even provision of non-medical benefits, designed to address some of these socioeconomic disadvantages. So we're actually, now having some evidence that makes a difference, and it seems to be a positive difference. So Boris, maybe you can talk a little bit more You're more of a policy-oriented guy. How both the Medicare Advantage plans, as well as policymakers, can really, build on and use these study findings to improve Medicare.
Yeah, absolutely. And I would just say that, apart from being interesting in their own right, some of our findings, or a lot of our findings actually, are highly actionable for health plans. So starting with our socioeconomic findings, these can help plans really target a lot of the interventions that Christy described. So if plans are able to recognize that some of their offerings have a lot more socioeconomically disadvantaged beneficiaries than others, and they can tailor a lot of the interventions and target a lot of their interventions accordingly. Um, and I guess uh, building on that and this idea that not all Medicare Advantage plans or not all Medicare Advantage patients are created equal. Um, our results really underscore the need for really fine-grained benchmarking when it comes to Medicare Advantage. So really, high-level benchmarks that compare your Medicare Advantage plan to the broader Medicare Advantage population. That's not going to be enough because it's not necessarily going to be apples to apples. So much more fine-grained specific benchmarks are essential for really Medicare Advantage plans understanding their performance, and Inovalon's data and analytics are well equipped to provide that kind of benchmarking. There's also opportunities really for health plans to understand not just after the fact how they're performing, but understand in advance what different types of plan features will end up doing for them, and really help fine tune their offerings in advance. They can also do other kinds of predictions, again, supported by analytics such as Inovalon's, to really understand what future health resource needs are going to be for different populations under different plans, and really, resource themselves in advance accordingly. And on the policymaker side, I think, this really underscores that, again, not all Medicare Advantage is created equal, because policymakers, they sometimes talk about it as just a monolith, a single program, and maybe point to some challenges that they see with the program. But I think our results point to the fact that some of those challenges that policymakers see, uh, they're not gonna apply to all of Medicare Advantage. There might be some plans that might not be doing as well as others, but um, that's not something that impacts the program as a whole. It's not a knock on the program as a whole, and there's a lot of really great and high performing things about Medicare Advantage, and so policymakers definitely need to recognize that any of these stories that they might be hearing about things going wrong in Medicare Advantage, that's only part of the story, just given how much variation there is in Medicare Advantage, and that ultimately a lot of Medicare Advantage, most of Medicare Advantage, is quite high performing.
Yeah, we know that there still are, both in Medicare Advantage and in fee-for-service, disparities in health outcomes in the Medicare beneficiaries, in the Medicare population. CMS, to really address that head on, to put some financial incentive behind reducing those disparities, is implementing this new health equity index that people are talking about. And so that's going to be part of the 5-star rating system for Medicare Advantage plans, maybe part of value-based programs eventually, and for fee-for-service providers. But what it really does is put a focus on the data that we've looked at, Boris, the socioeconomic data that we were able to pull in, and really show that if we're the same age and we're the same have the same chronic conditions, but I'm poor and you're very wealthy, my outcomes are going to be better even if we get the same care. So I need like a little additional, it takes more, right? It takes more to address some of those other barriers to access to treatment, to the likelihood you'll get screenings, to all of those things, the likely you'll be readmitted to the hospital. And so by measuring it using the kind of data that we have and stratifying, quality outcomes by some of these socioeconomic characteristics, what's really driving the higher readmission rates? Maybe it's limited English proficiency. I'm not understanding what you're telling me I have to do to stay out of the hospital, and not end up back in the hospital or the emergency room. Maybe it's, transportation. Maybe it's lack of, having a caregiver to, a support at home. But it takes, it's never a one size fits all. And so you really need the data, and plans need this data, and they need to understand the socioeconomic disadvantages their members are facing, as well as their clinical limitations, right? So that they can have we can all live our best life, right? We all want to be the best person we can be and live our best life. So I think it's just, this work really underscores the importance of the data. And I just also wanted to add another message for our audience that you touched on in the beginning, and that is how this collaboration, this research collaboration that we've been, working on for a couple years now, and we continue to work on, between a company like Inovalon, a data technology company, and Harvard Medical School, the researchers at Harvard Medical School, really can serve as a model for future industry academic partnerships that, as you pointed out, are stronger together. The model that we operated under worked really well. We both have experienced really qualified researchers. We all have, deep analytic expertise, deep policy expertise. So we kind of leaned in on our collective strengths, and we collaborated on everything, right? The study design, building these big, complex linked analytic files, conducting the analysis, which were, really high level statistics and difference in difference modeling and all of that, interpreting the findings, explored the data lots of ways, and then writing it up and presenting the findings. We worked together, step link all along the way. And so this is really a case where the synergy, sort of resulted in findings that bring really unique and new knowledge to the industry and to the policymakers and to the health plans on the value of Medicare. And neither one of us could have done that on our own. So I think, just want to give kudos for, Harvard, Boris, for pursuing this relationship, reaching out, and we made it happen. And I'm really proud of the work we've done together, Boris. And it's not over, right?
Yeah. I'm likewise, very excited and just really thrilled with what we've been able to do today. And of the many limitations that Harvard and myself would have faced on our own, again, one limitation worth mentioning is just the data limitation. So even though Harvard does buy, data from some of the usual suspects, and we also license all of the standard CMS files, even with all of that data, we didn't have close to the kind of visibility on the U.S. healthcare system as what Inovalon has, because it's just, a statement of fact that Inovalon has more data when, in combination of its own data and the qualified entity CMS data that it also has under its purview. That in combination is substantially more data than CMS itself has, or that any policymakers in the government have, and just that data has been able to give us really unique visibility, has allowed us to answer all kinds of previously unanswered and important questions. And then, as Christy was alluding to, it's also been really powerful um, working together, just brainstorming ideas together, and then even just doing the analysis together. 'Cause I know some of the challenges of working with healthcare data, having to come up with different kinds of measures or outcomes from scratch, programming things from scratch, as we often end up doing at Harvard. Because even the measure library that we've been able to build up over many years of work on data, it's limited. And then so being able to partner with a company like Inovalon that has an extensive measure library already in place, much bigger than ours, has really allowed us to get out of the gate much faster, do this research much faster and much more comprehensively. Uh, on our own, even if we had the data, it would have taken us probably a decade to do this research rather than getting it done in pretty much a year as we have.
And I always tease these guys because I say Inovalon moves quick, and I know academia moves slow, but actually they've kept up, man. They've kept up with us. So I love hearing you talk about our data, because I always say that our data set is the biggest data set that nobody's ever heard of. Lots of folks haven't heard about Inovalon's data. They know Inovalon maybe, and they know we do a lot of work with health plans, but I don't think they know so much about all of the data that we have. And because it's all primary source, the fact that we can literally link and longitudinally track patients over such long time periods, which is really rare, I think. And then, I've been working for 12 years to build this social drivers of health database that we now have, a data warehouse, and it's chock full of really critical social drivers of health data that we can link at a really granular level to all of the members in our data. And that adds a layer of that you just really can't do research anymore unless you are factoring in social drivers of health. I think everybody now understands that, but few people have the ability to do it, or to do it at such a granular level. We link it in at a very near neighborhood level, 9-digit zip code. There are 32 million 9-digit zip codes in the United States. That's 5 to 10 households. So it's very predictive of health outcomes, health behaviors, and it's just so important to layer that in because of it contributes to 80% of our health outcomes. We said that in an earlier study, and there are several studies that have shown that 20% of our health outcomes are due to the clinical care we get, 80% due to other things. So we got to look at those other things, and that's what we've been able to do, or at least one of the things we've been able to do in this research. So we are getting up to time. We always run out of time. Boris and I could talk about these things all day long, and we'd be happy to talk to you about these issues. If you have any more questions, please feel free to reach out to us anytime. Be sure to download the study from Inovalon's website. There's also an on-demand webinar, as Boris mentioned, that we did with Susan Denzer, who's a powerhouse and just always has really interesting commentary. She moderated for us, so that's something else. And then just thank you for taking your time out to join us and listen in. And we really appreciate this, being able to do this, and we'd love to talk to you about it more. Thank you.
Thank you.